Good morning, everybody. Anders, thank you very much for that introduction. I might have known he would mention the word old not once but twice, for which I thank him. It's an absolute pleasure to be back in Sweden. It doesn't take much to get me back here. I love it, and it's great to be here once again. What I'd like to do in this introductory talk is to make the case why it's important to get the diagnosis right. Why should we bother finding an association with a connective tissue disease when a patient perhaps presents with a lung disease? I'd like to start by doing that and then continue by discussing a number of the challenges that face those of us who have to try and deal with these often complex and difficult problems. This is one of my favorite views of Stockholm. This is a great hotel that I had the privilege of being in, looking at over at the City Hall when I was invited to be Jan Wellström's opponent at his PhD. So I'd recommend this to anybody. I don't think I could afford it now, but I think it's probably a wonderful view still. So it wasn't that long ago where all of the rheumatologic or connective tissue diseases, I'll use those terms interchangeably, was underdiagnosed. And even when they were diagnosed, historically, they were lumped together as though somebody had rheumatoid lung or connective tissue disease lung. And it wasn't just the rheumatologists who were guilty, if you like, of lumping, because also, look at the author here, this is Margaret Turner Warwick, quite a few years ago now. This was probably the first medium-large study, although, look, there's only 43 patients, but it was larger than anything that had preceded it, in what the British called cryptogenic fibrosing alveolitis, but which is now known as idiopathic pulmonary fibrosis. When you don't bother looking at these patient characteristics except to see at the bottom. A full 20–25% of these individuals had an associated collagen vascular disease. So the lung doctors lumped everything together. And I want to make the case that the concept of connective tissue disease, or even more specifically rheumatoid lung disease, is really unhelpful, and that there's a pressing need to be absolutely precise about the diagnosis. And there are some lessons we can learn from idiopathic disease that just make this point of the dangers of grouping diseases. I'd like to suggest to you that the outcomes in rheumatologic disease are different than with idiopathic disease that shares the same pathology, and that therefore different management strategies are needed. So the argument is if one can fulfill all of these criteria and convince you that these are important, then I think that starts to make the case of why we need to get the diagnosis right. So look at this. These are the commonest connective tissue diseases here listed, the areas in the lung that are affected. How can we possibly call all of this lot rheumatoid lung or rheumatological lung or connective tissue disease lung, where the pleura, the airways, the vasculature, and the diffuse parenchyma can be involved? So grouping is extraordinarily unhelpful in this context. And look what happened when the idiopathic docs lumped everything together. So here were 78 patients seen at the Royal Brompton Hospital during this decade, diagnosed CFA, this is IPF, and then following the publication of a novel histopathological classification from Katzenstein and Myers, our pathologists went back and now reviewed the biopsies into the new categories of usual interstitial pneumonia, non-specific interstitial pneumonia, desquamated interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, and now looked at having taken a group that were all called the same thing when they were diagnosed during this decade, now looked at the outcomes of these patients, now classified more appropriately. And if you've got DI, PRB, ILD, people live for a long time with this disease. There are exceptions, but generally speaking, they live for a long time. NSIP has a worse outcome, and UIP, the histopathological definer of idiopathic pulmonary fibrosis, carries by far the worst prognosis. So here's another example where grouping is actually unhelpful. It's really unhelpful for the patient, where you're trying to talk about, how long they may live and what treatments you should try and the benefits of drug against no drug. To have grouped them together is a massive error. And here we see the benefits of splitting them up. And this applies to rheumatologic connective tissue disease too. So what I'm showing you here are a group of patients from South Korea, a very decent group of patients, 269 of whom had idiopathic disease, 93 had a collagen vascular or connective tissue disease related lung problem. And this is survival with connective tissue disease. And here is the overall survival with idiopathic disease. It's different. The pathology is the same, but it's a different outcome. And these individuals also, when you split them up into the individual histopathological patterns, again, there appears to be a survival advantage whether these folks had non-specific interstitial pneumonia or usual interstitial pneumonia in the context of their connective tissue disease. Pretty well all of the patients were on treatment, so this was treatment-independent effects. Breaking them down, the rheumatologic connective tissue disease patients, into the connective tissue disease. So in other words, here are individuals who had the usual interstitial pneumonia pattern of pathology but didn't have rheumatoid arthritis, so these were all of the others. This is the group who did have rheumatoid arthritis. This is idiopathic pulmonary fibrosis. It appears, although as you can see the numbers were small, but it appears that usual interstitial pneumonia in rheumatoid arthritis might be a bit worse than having it in the context of some other CTD. So dividing the connective tissue diseases is also important and not lumping them all together. And it makes a difference because once you now define these patients well, you can do clinical trials of therapy. And this is the Scleroderma lung trial from the United States, a terrific collaboration just in the US, shows you what you can do with networks. You can do trials, but to do that you've got to A, get the diagnosis right, and B, be very precise about it. I'm sure many of you will know the trial design, but just in brief, patients were given either cyclophosphamide or placebo for 12 months, and then they were followed up for a second year when they were off therapy. Now, they weren't all off therapy. The individual clinician was allowed to decide to keep the patient on treatment or not. In fact, the majority of patients came off treatment. So the second year was sort of almost a washout phase, if you like. And indeed, as I've just said, most of these patients who were enrolled in the study took part in this follow-up. And what you see is that after the first 6 to 9 months, there is a divergence, so that by 12 months, there is a definite advantage in those individuals who took cyclophosphamide in terms of the change in their forced vital capacity. What most people now show you is this bit, that after 2 years, there was no difference in taking cyclophosphamide or not. Remember, most of these people have now stopped their cyclophosphamide, so maybe not a big surprise. But what I like to highlight is the 18-month figure. Look, at 12 months, there was a divergence in behavior, but it was even bigger 6 months after stopping drug. And for me, that's a really powerful statement that there's a biological effect that may outlast the time in which the drug is taken. So for me, that is the most powerful index that this drug works in this condition. And that's crucial because when you look at the side effects you can get from cyclophosphamide, it's important that you get a good balance that outweighs the bad effects. So I think, and I hope in these few short slides that I've given all of us enough reasons to say it is sensible and important to differentiate connective tissue disease from idiopathic disease and the individual forms of connective tissue disease from each other. It will have an impact on what we do in the future for future clinical trial studies of therapy. I'd like to move on to some of the challenges, and I think the first and probably the most important thing to say about this is when you see a patient with idiopathic interstitial pneumonia or a diffuse fibrosing lung disease or an organizing pneumonia, always think that it could be a connective tissue disease. And of course, the lung disease can come first with no evidence at all of a connective tissue disease, and that's tricky, obviously. Subtle forms of connective tissue disease can be missed, especially by lung docs who maybe aren't focused on it. And this makes the crucial point of the multidisciplinary care. And I've enjoyed over the years a working relationship with Carol Black, a rheumatologist. I was a lung doctor. There's a terrific interaction here, and I know this is reproduced here in Sweden and also in the United States. Lung disease can be missed. Back in the old days, it was always missed till it was too late, and the patients who were sent to me was my experience. It's getting better, but it can still be missed. I'd then like to fly a couple of flags with you. The first is the concept of lung-dominant disease, and I'll come back to what I mean by that in a minute. I'd like to show you what I think are reasonable algorithms for what lung problems you look for with a patient who presents with their connective tissue disease, and vice versa, when you need to send a patient to a rheumatologist. And my second kite will be to make a case to classify the connective tissue diseases and some of these form-fruste rheumatologic diseases based on the pattern of autoantibody they carry, rather than any other arbitrary ARA-type criteria. So let's just start and make the first point. So this is R.A.A. Fisher's work from National Jewish. Here and throughout, I'll be using a lot of his work, showing some of the slides he gave me, because we had a lovely relationship at National Jewish for 5 years. So here he asked the question, could there be some subtle forms of connective tissue disease patients buried under the umbrella of idiopathic pulmonary fibrosis? So he reviewed 285 people who were evaluated at National Jewish. They had a program, so there was a consistency of management here. And these patients had an anti-nuclear antibody as part of their initial evaluation. And of these, 97 patients had what the National Jewish guys define as a suspiciously high titer, anything above 1 in 40. Obviously, the higher, the more suspicion, but they defined this as anything above 1 in 40. There were 97 patients. And of these 97 patients, 25 of these had a nucleolus staining anti-nuclear antibody. And of those 25, 13 had the THTO autoantibody that is moderately highly specific for systemic sclerosis. So the question is, do these patients really have idiopathic pulmonary fibrosis? Or do they actually have a connective tissue disease that is yet to manifest its connective tissue disease? Or maybe the docs just missed the subtle features that would define the systemic sclerosis. So they went on and looked at a much smaller population of patients where sclerodactyly, skin thickening, digital edema, all the classical scleroderma features were missing, and looked at the antinucleolar staining positive population of 6 individuals. One of these had the anti-DNA topoisomerase antibody, SCL70, and that individual was negative for the TH2O autoantibody. All 5 of the SCL70 negative patients were THTO positive. But then when they drilled down, actually really looked back at the clinical features, looked back at the patients, all of them had subtle disease. All had telangiectasia. 4 of them had Raynaud's. 3 of them had esophageal hypermotility. So indications that what they were seeing actually was not an idiopathic disease, but a disease which was a connective tissue disease, presenting their connective tissue features very subtly. The reverse can be true. This is Julie Dawson's nice study from Liverpool many years ago now. But what she did was she took 150 unselected patients with rheumatoid arthritis. She was a rheumatologist. And she wanted to ask the question, look, how often are we missing lung disease and does it really matter? And all of these individuals, in addition to their clinical assessment, had an HRCT of their chest, conventional radiography, within 4 weeks of pulmonary function tests. And the questions were, how much subtle lung disease was there? Pretty well 20% of people had a diffuse fibrosing pattern of disease on their CT scan. Half of them had symptoms on auscultation of the chest, but look at this, a full 82% had a reduction in their gas transfer. And I think we'll probably, and I sense we almost certainly will come back to this when we talk about maybe the lung is the origin of rheumatoid arthritis, and maybe we're seeing other evidence here that in a reduction in DLCO, the lung is maybe hit first, or there's where the problem starts, and maybe that's where the autoantibody comes from. And it is important. Here are deaths from patients with rheumatoid arthritis, and I'd just like you to focus on this line. This line shows you the relationship of people who died because of an interstitial lung disease complication of their rheumatoid arthritis, with the denominator being all deaths. And look, this is from just below 5,000 to over 6,000, so 20% increase in mortality over a decade. And it's estimated that lung complications are directly responsible for some 10 to 20% of rheumatoid arthritis-related mortality. So it is important There are enough patients out there. I believe that lung disease and the connective tissue diseases is the next big challenge for lung doctors. And here we have a group of patients where there are enough numbers worldwide, with enough people interested to do some very decent clinical trials of therapy, because it makes a difference. I want to move tack slightly now to the concept of lung-dominant disease. And what I mean, the lung doctors will understand this. You see a patient who appears to have an idiopathic disease, but there's just something about them that makes you think this might be part of a connective tissue disease. Maybe they've got a little bit of Raynaud's, maybe a little bit of this, maybe a little bit of acid reflux, just something which starts to make you think this might not be an idiopathic disease. And I want to fly this kite. This is something that R.A. Fisher and I put together in something that was published a year or so ago, for discussion as much as anything else, because you'll see there are a lot of presumptions in what I'm going to show you, but I'd be interested in your feedback, and clearly in future our concepts will need to be proven or disproven. So let me just set the scene. This is a Japanese study where they looked at 22 patients who had been diagnosed as having idiopathic pulmonary fibrosis, and for reasons of comparison with a group of individuals who had a tRNA synthetase syndrome, they took these patients and evaluated all of the tRNA synthetase autoantibodies. And 10 out of these 12 individuals had the PL12 autoantibody, but no features of a connective tissue disease. And they defined this group of patients with IPF who had autoantibodies. Very similar scenario. This is REA's work from Denver. And here they looked at a number of individuals with idiopathic interstitial pneumonia who had some subtle clinical features of connective tissue disease, but not enough to define using ARA criteria. And some of them had very softish features of a tRNA synthetase syndrome. So 3 had a CPK that was elevated, 2 had a little bit of muscle weakness, but not the full constellation. Some had mechanic hands and so on. 9 out of these patients had a PL7 or a PL12 autoantibody. They described these patients as having a connective tissue disease that presented with the lung. So what one individual may call idiopathic pulmonary fibrosis, RA preferred to call these CT-ILD, although they would not fulfill the criteria, the ARA criteria. And isn't it inconsistent? Here's a 50-year-old woman who has keratoconjunctivitis sicca, a positive SSA autoantibody. That patient can, using the published criteria, be diagnosed as having systemic Sjögren's syndrome. Here's the same 50-year-old woman with the same autoantibody and a number of features on her surgical lung biopsy that were done because she presented allegedly idiopathically. And these are all pathological features that have been associated with the presence of a connective tissue disease. So why should lung features that are pretty consistent with a connective tissue disease and an appropriate autoantibody not be called Sjögren's syndrome, while a clinical manifestation of dry eyes and mouth and so on should be allowed to be called Sjögren's syndrome? So it's because of these middle ground patients that we sat down and had a think. And we decided that we would term these, you can call it what you like, we called them lung-dominant connective tissue disease. In other words, the lung problem was the dominant problem. Whether it was the first problem or just the main problem, it was lung-dominant. And as I've articulated, these are individuals who had a flavor of disease with some soft clinical features, maybe a bit of Raynaud's, some autoantibodies, those histopathologic features I've just shown you. And we've proposed, and this is to be shot down or proven, whichever happens, the provisional criteria for this entity. So these people have these patterns, and we'll hear a lot more about this later on this morning, of histopathology on their surgical lung biopsies, or a CT scan that is suggestive of these patterns. They had insufficient features outside of the lung to call this any specific connective tissue disease, and obviously no other etiology. And we suggest that any one of these autoantibodies, so a high titer antinuclear antibody or rheumatoid factor, and these much more disease-specific autoantibody subsets if they had any one of those or two of those histopathological features I've suggested to you. So too many lymphoid aggregates, too many germinal centers to call it true idiopathic disease. Pleuritis, you don't get that in idiopathic disease. So if you see it, think about a connective tissue disease. And this dense perivascular collagen, which I think others have now reproduced, but this is very much a Denver thing, where a lot of collagen around the vessels, they always makes them go back. That always makes them go back and think of a connective tissue disease. So we put these up to test, for us to do prospectively in the future, for you guys to say this is rubbish, or maybe that's interesting, but just to try to get a handle on this very difficult group of people who don't have the full features of a connective tissue disease. And we would argue that these require objective and measurable criteria, which we provide. It doesn't require non-specific extra thoracic features, just this hint, more than a hint, of an immunological process ongoing in the background. Defines that it's different from an idiopathic interstitial pneumonia. Too often they're grouped with the idiopathic interstitial pneumonias, given the same prognosis, but they've got a better prognosis generally, as I showed you earlier. And acknowledges this feel, but without being able to put it into words. So I'd be very interested to hear your critiques of that. And this group of patients may evolve either way. We just don't know. They may go into or remain idiopathic. They may never develop a full-blown connective disease, or they may. And I can tell you, the paper just published, ARIA, has shown a subset of patients who presented exactly like this, who then over the period of 18 months to 2 years developed the full-blown features of rheumatoid arthritis. So at least in that small subset, doesn't prove it, but at least provides some support that this may be a reasonable approach to take. So I now want to articulate what I would suggest should be done by a rheumatologist, dare I say it, in a room which is at least half full of rheumatologists, what lung investigations I think would be reasonable in connective tissue disease. Now I'll start with systemic sclerosis, because this is how we operated at the Brompton for a good 20 years, and this is how they operate at National Jewish too. So the diagnosis of systemic sclerosis is made, and that's why they're referred to the rheumatologic clinic, and all patients should have a chest radiograph and lung function tests. And if they're normal, we would recommend repeating those every 3 to 5 years, just to be sure nothing is developing. And maybe after 15 years, you can say, well, okay, it's not really going to happen, because it tends to happen within the first 7 or so years of developing systemic sclerosis. But if either of those are abnormal, we suggest a CT scan needs to be done. And if that's normal, then the patient needs to be evaluated for the vascular form of systemic sclerosis. And as you know, this disease can hit the vessels alone, manifesting very like primary pulmonary hypertension, or it can attack the interstitium of the lung with a diffuse fibrosing process, generally the non-specific interstitial pneumonia pattern. If the CT is abnormal, but typical for non-specific interstitial pneumonia, then we tended not to biopsy those individuals, and then the only question that remains is when to treat and how to treat. If there's anything atypical about the CT scan, we would recommend a surgical biopsy, and particularly if there's any element of organization. That's very unusual in scleroderma, and should make you think of complicating factors. Infection, alveolar cell cancer, often a big mimic and not uncommon in systemic sclerosis. So extrapolating this suggested algorithm into the other connective tissue diseases, I would suggest a very similar pattern should be followed. All patients should have a chest X-ray or PFT. If they're normal, follow up every 3 or 5 years with repeat studies. And if it's abnormal, the patient should have a CT scan, and then depending upon the pattern and depending upon the disease, you can have all sorts of things. Airway disease, obliterative bronchiolitis, organizing pneumonia, and so on. So then you would follow lung-specific investigations to define this disease most appropriately. People may say, well, why don't you do BAL? There was a fashion, particularly in the United States, to use bronchoalveolar lavage as an index of disease activity. If this was abnormal in terms of the percentage of neutrophils and or eosinophils, this is an index of activity and was used as an entry criterion for the scleroderma lung trial. But the Scleroderma group, the network from the United States, have subsequently suggested that BAL is not a predictor of disease progression or cyclophosphamide responsiveness. And we of others have shown that in actual fact, not only in idiopathic pulmonary fibrosis, these filled dots, but also in scleroderma, the neutrophils come in when the disease is more extensive. So it's a measure of bad disease, not active disease. And of course, bad disease had to have been active to become bad disease, and I think that's where the mix-up occurred. So BAL is neither a defining criteria in my view, nor should it be used as an index of who you should treat or not. Spinning it round, when you see patients with an apparently idiopathic interstitial pneumonia, who should you send to the rheumatologist? You can't send them all. So the way we operated at Brompton and R.E.A. Fisher at National Jewish is that if a woman presents with an apparently idiopathic interstitial pneumonia who's 50 years or less, they should be sent to a rheumatologist. Any of these manifestations that I've talked about earlier, they should be sent to a rheumatologist. Pathology that has those features that I've already discussed, or suggestive autoantibodies. So a hint, send to a rheumatologist, work together, everybody wins. And lastly, just to finish, this is the second kite I want to fly. And I would want to just make an argument that maybe we should forget the ARA criteria and use autoantibodies as a defining criteria. And I'm going to give you a little cameo that hopefully supports that. We know there is an association between particular autoantibodies and diffuse lung disease and the known connective tissue diseases. So specifically, scleroderma, polymyositis, dermatomyositis are really good examples of this. As I've tried to convince you, you see autoantibodies in people who don't have classical disease, the lung-dominant form. So how about exploring an autoantibody-based classification? And I think they're more than flags. So if you look at the lungs of many patients with connective tissue diseases, you see these. These are lymphoid follicles with true germinal centers. They're making antibodies. Are they making autoantibodies? I'd like to think they are. I believe for sure they are in rheumatoid arthritis, but maybe they are in other diseases, and maybe triggered by smoking, and I know we're going to hear a lot about that later. Scleroderma, this is the diffuse, fibrotic, non-specific interstitial pneumonia that characterizes the diffuse lung disease of scleroderma. And here is the vascular disease. Some people get both, but generally they polarize. And so the diffuse lung disease, lone vascular disease, and they're defined by their autoantibodies. A speckled pattern ANA with an anti-centromere antibody. These are the people who get the vascular disease that are at risk of pulmonary hypertension. The patients with a more homogeneous ANA, particularly if they have a nucleolar pattern, and especially an anti-topoisomerase antibody, pretty well all of these people get some fibrosis. It varies, but pretty well all of them get some fibrosis. And what also is very intriguing is that the autoantibody pattern and scleroderma, they're mutually exclusive. Very few people have both. You see it, you never say never, but it is a mutually exclusive situation. And so I'd like to suggest too that instead of defining classical CTD using ARA and idiopathic disease the way we lung docs do, we incorporate all of these and look a bit more closely at autoantibody patterns. And maybe we're going to be able to anchor these diseases based on their autoantibodies into a much more logical defining process. And I'm going to finish with not my words, but words of people far wiser than I am. On the definition of systemic sclerosis, and these eminent authors said the criteria that emerged were not surprising. So it was a bit circular. You see patients with scleroderma, you say those are the features, and then you define it, which is a bit circular. And these authors said that it's likely that a very different set of ARA criteria would have emerged if dermatological patients had been used as the controls. And the people who said this were none other than Carol Black and Alan Silman. So the defining criteria, I would suggest, need to be revisited, and I hope I've made at least a small argument to suggest that it in future could be autoantibody driven. So what I've tried to do during this opening presentation is to say it is important. It does matter to make a diagnosis of connective tissue disease associated lung disease because it affects prognosis and management. Therefore, screening is important for connective tissue disease in patients who present with lung disease and vice versa. that subtle and lung-dominant CTDs exist, and that's where we need to work with our rheumatological colleagues. And finally, to finish with a question, is there a case for an antibody-based classification? So again, Anders, thank you very much for having me back here, and thank you very much for your attention.